All right, Mayresh, you can start.
Yes. Hi, everyone. Good evening. First of all, thank you for joining in on a Friday evening, and we hope to hear a lot from you. And we hope this session is more of a discussion rather than just us discussing the paper. It is with great pleasure I would like to introduce Niharika, who is also the author of the paper that we are going to discuss today. Niharika has done her bachelor's and master's in genetic counseling from the US, and in this paper, she has spoken about her experiences about a genetic counseling rotation as an intern in India and trying to kind of give us some comparative analysis of genetic counseling practices in India and the US. And there are a lot of interesting takeaways in the paper which she has spoken about. And we really thought that it would be interesting to discuss this with the genetic counselors in India and kind of get their view on it. So to begin with, Sukriti, can we share the paper? The first part or the first thing that caught our attention as the GC Journal Club while we were reading this paper was where Niharika talks about the VUS thing in India, wherein like we see that the Indian population is very highly underrepresented when it comes to the genetic variants that are very specific to our population, or how the databases still need to be updated with the information we have about the genetic testing in India. And so she talks about a very unique experience of getting a higher number of VUS encountered in Indian setting when compared to the US. So Niharika, would you like to talk about how was the experience, and when you wrote about this, like you said that there's a higher incidence of VUS among people of color, and how, as a genetic counselor, you encountered this disparity, and what is your take on it?
Yeah, of course. So, since I got my education in the US, when we were in our genetic counseling training programs itself, they did emphasize this was something that they emphasized that there is this disparity where most of our research is based on European populations. And so, as a result of that, consequently, it just makes more sense that variation within European populations is more studied. And so, there's a higher likelihood of having definite answers in terms of either pathogenic or benign answers as opposed to uncertain answers just because every time someone who hasn't been studied as much undergoes genetic testing, we're more likely to see variation that we haven't seen previously, that hasn't been reported previously, increasing the rate of VUSs in these populations, often of color. And so that was something that was like just part of my general education. And I found it interesting. And I didn't realize the extent to which it had practical implications till I first came here and started by doing my rotations over here. So when I was doing, because before I came here, I had done a few rotations over there and I was used to what genetic counseling looks like. Like I saw a lot of pathogenic, likely pathogenic variants. And also, okay, like, I mean, there was a high frequency of VUSs, but it wasn't to the extent to which where I came over here where practically every appointment has at least one VUS. Like we might be receiving a few proper, nice diagnostic variants, pathogenic, likely pathogenic, occasionally, which is lovely. But the vast majority of them tends to be VUSs, which is a burden both on the patient as well as on the clinician because it is so complex for the patient to be able to understand this uncertainty when it's so difficult for us as clinicians to describe like grasp that uncertainty as well. There's a lot more clinical piecing together of puzzle pieces that has to happen in order for us to actually interpret the significance of these findings. And so I that was something that really stood out to me when I first started over here. The higher frequency of boost results, the extent to which they were part of our daily conversations. And and I've discussed this in the paper as well, but I found that that also led to a difference in terms of how we deal with VUSs in
Mhm.
both good and good, both good, I mean, quote unquote, good or bad ways. But um, like I've mentioned how typically in a cancer context in international parts of the world, like in the US specifically, and I'm assuming internationally as well, when you get in cancer counseling, they typically think of findings as either findings that will change your clinical management or findings that won't change your clinical management. And so when a VUS pops up, it gets counted as a finding that doesn't change your clinical management. And we disclose that as genetic counselors. We disclose that as very similar lines to how we disclose a negative result. So I remember in my counseling sessions over there, if if there was a VOUS, we'd just say, "Oh, we didn't find any pathogenic variants that would increase your risk for disease. By the way, we also found this uncertain variant. Most of these tend to get downgraded over time, but just keep following up with us on a regular basis." As opposed to when I came over here, just because variation is not studied as much, we can't give patients that, oh, it's probably going to be classified as likely benign over time. Like it's not that clear. And so we have to add this little edge of uncertainty of, oh, this may be relevant, it may not be relevant. There's a lot of times when I've seen VUSs in a BRCA gene where I see multiple generations of family members affected by breast cancer, and I feel so strongly that this is it, but it hasn't been characterized before. And so I don't like, I would never counsel a patient over here the way I would over there, saying like, oh, it's just we haven't found anything harmful, like this is likely going to be reclassified in a few years or something like that. And like that's how the specific case I mentioned in this section as well, where the counselor I was working with actually recommended clinical management on the basis of a VUS, which isn't something that would have been recommended over, like would have been recommended in the US. Like you definitely surgical management decisions aren't something that we recommend on the basis of VUSs over here also. But any clinical workup on the basis of uncertain findings, I think that just speaks to and attests to how the higher level of uncertainty leads to a greater burden on the patient and the clinician. And perhaps we are overworking up VUSs in some cases. And yeah, that's I that's basically my experience with respect to uncertain findings. And I am interested to hear your thoughts, and if anyone else has any experiences with VUSs and how they manage them in their clinic. Do they manage them similar to what I was saying for India? Is there anyone who thinks similarly to all VUSs are kind of irrelevant? Or excited to hear anyone's thoughts.
I
Yeah, I
wouldn't
think
say that a VUS is just not significant in this in our country, because so I am not counseling right now. I'm a genome analyst at the moment, and the number of cases we get wherein the clinical indication is just so vague. And
Yeah.
there is and most of the times there are prenatal samples, right? And in those cases it is even more difficult to kind of see a variant right in front of you which could have some sort of a clinical correlation, but then it's a VUS. So you have to
Yeah.
think so much about even just shortlisting the variant, or even just getting a second opinion about the fact whether the variant should even be reported. But then even if it is reported, especially in a prenatal sample, it's just given with so many disclaimers. So
Yeah.
I wouldn't
Yeah.
say that it's not of any significance in our country.
Definitely. It makes it so challenging to think about, especially from like a reproductive standpoint that you brought up, to think about the ACMG guidelines that say, oh, you can't make medical management decisions, especially not
Hmm.
reproductive decisions, on the basis of uncertain variants. And when we see, like I really typically really avoid over managing a VOUS, and I don't like to go against those guidelines. But I think we've all seen in clinical practice when there is like a biochemical diagnosis but a VOUS genetic result, and like that that feels like it should be actionable on a prenatal basis, but the guidelines say certain things. And so yeah, Mayuresh, you were also going to say something, right?
yes, I definitely would agree with Sukriti that in Indian genetic counseling setting, when we see a VUS, we definitely don't lean towards like, okay, it's going to be likely more like likely benign, but more like if cases come up, there is a chance that it could be classified as pathogenic. At least in cancer setting, when we encounter a VUS and patient is like the only person who is affected with the cancer, and they have family and siblings or like even future generations who are like, okay, there is an uncertain significance which will be classified as pathogenic, or maybe something significant will come in the future. and they're more worried that are there any recommendations for us? And in that point, we are kind of in a thing that okay, there could be this could be classified as pathogenic, so they are more keen to know what recommendations do they have. So our counseling completely changes. I have seen like a lot of counselors not follow like it's going to be likely benign, but it's like we don't know at this point.
Hmm.
And if further studies come up, because our population is so underrepresented, we we cannot confidently say that it's going to be likely benign. Like we said in the US, it's more like it could be benign. So
Yeah,
I think
yeah,
counseling here more tilts towards a very uncertain edge wherein they are like,
yeah,
okay, you can be extra cautious because there is something which we don't know is if it is relevant yet, but then we cannot say that, okay, it's going to be
yeah,
fine. There's nothing, no cause at all. Anybody else would
definitely.
like to add on to something interesting to VUS and how they have counseled their patients with VUS?
So hi Niharika, hi Mayuresh, hey Sukruti. This is Shivanjali, and I broadly work in a reproductive genetic segment, and a lot of VUS is coming up, especially when it is pediatric case. And what you see is it is a VUS reported, and you actually have a good, fair clinical and genotype match happening and of US. So that's very difficult to counsel also. Challenging when you tell them that the literature is not enough or it is not the evidences are not supporting it is of US. Currently cannot comment on it. We need to again reclassify it, revisit us. So they don't get the point of revisiting
Hmm.
because whatever in an Indian setup, people expect everything happening in the same session. So from end to end, giving out management is very difficult. Saying that this is the cause of the condition is very, very difficult. Putting down it, putting down that too on the paper, saying that there is a match, but of US. And then there is another pregnancy associated already 16, 17 weeker, then it's way challenging. So these challenges, I think, in an in a day we see so many cases like this, becomes very difficult for all of us. And then we go back to our bioinformatician, our genome analyst, and then we again have conversations saying, "Ki, what is this? How are we going to look at this?" So that's I think it's a teamwork again, but making it more easier for patients is it's still a challenging job for counselors and clinical geneticists today. So VUS definitely has so much more to tell us. And we don't know if it is going to be benign or if it is going to be likely
Yeah.
pathogenic later.
Yeah, definitely. You brought up such an important point about like the multifaceted role that each person, the burden that each person faces with the VOS. Like obviously, there's the patient primarily who's dealing with like neither yes nor no information. Then there's the lab end, each end of the lab end, identifying variation, identifying when it should like when it should be reported, when it shouldn't be reported, all the discussions that go on within the lab, which is multiple conversations, then reaching the clinician at the last step who has to tell the patient that, oh, there's something that we don't know about. And it's just so many steps of confusion and challenges that everybody faces for this.
And I would agree to Sukruti where, especially when it is a prenatal setup, and you
Yeah,
get vague information coming up, either from the ultrasound, blood reports, or something else, and then you end up having a VUS
yeah,
and or a compound hit. One is likely pathogenic, one is a VUS, and we have no phenotype genotype match. And there is
yeah,
ACMG guidelines asking us to either report it, not report. They're very challenging. I mean, this is going to be way. I think we need to have more conversations over this to really come down to lines where we can report out, we can discuss it with patients,
yeah,
and necessary. Otherwise, in there are so many testing happening, AMNI or CVS, vague VUSs where there are absolutely limited or no match even today.
yeah,
And I think it becomes even more difficult in those cases wherein the starting of the gestation there is very less, just one or two
Information.
things we're able to see. There's this polyhydramnios at first, or just a mild thing, and then later on, as the pregnancy progresses, there's just more information that we get, and with that information, when we're asked to just reanalyze the sample, then we come up with a VUS. How do you even explain that? How do you report that? What do you write in the report that, okay, we didn't we might have gotten it before, but then it wasn't matching. Now it is somehow, to some extent. Ma'am, how do you counsel such cases? Have you counseled such cases?
We do have such cases where we've reported out prenatal normal, and then when we have the the patient coming in with some kind of developmental delay or some kind of intellectual disability, wherein explaining them here still becomes easier because we have our guidelines in place where we cannot report out everything, especially where something is not seen in ultrasound. So we know that ultrasound cannot tell us about developmental disabilities or intellectual disabilities. So there we still have guidelines to portray and tell them that yes, this is what is there, and that's why the prenatal diagnosis report came out negative. But then when once you have one or two good relevant um, ultrasound abnormalities, and we're giving out a normal report because some kind of variations which cannot be reported out today has been seen, and postnatally it still becomes relevant, there you face a bigger challenge. And we've got such cases also where you would not report out in a prenatal setup where we've seen those variants. And when the patient comes in, we actually have reported them and said that this could be the cause. And then maybe reclassified it also as likely pathogenic and reported out.
Yeah. And also in Indian scenario, it gets pretty challenging when you're dealing with a VUS where the patient has not had a pre-test counseling session.
Yeah, yeah.
Right?
Yeah.
They were completely
That's a
unaware
bigger
of,
challenge, I think.
because their entire attitude, like for most parts, it's not anything wrong with the patient, but they have this attitude that, okay, they're either going to find something pathogenic or non-pathogenic, like any other diagnostic test
So I
available,
think
like
Vanesh,
mammography.
patient does not even know these terms at times that this
Yeah,
pathogenic variant is unlikely pathogenic variant is
true.
VUS. So post pre-test counselings, I don't know if they're really happening. And I think they need to be referred to counselors where they can sit down, give time enough, where they can explain them all of this. Because in rush, you cannot explain them. These are high-end testings, huge data coming out. And we need to really explain them, what does this mean?
Yes. That's a very interesting point. And like also this highlights the point that Niharika has mentioned, the accessibility of testing and accessibility of testing with a generic counseling session or a session where they know what they're signing up for, including like the pathogenic finding and also the VUS. And I think in terms of Indian setting, this accessibility depends on where you are located, like urban setting, semi-urban setting, and rural setting. And it almost catches us in off guard that we might feel that, okay, in an urban setting the patient is going to come in with a very well informed outlook, or they're going to have some knowledge from the doctor. But then it's not the case. It's always a unique case. You can have an urban patient who has no clue about the genetic testing, and they are just there because their doctor suggested this. And or you can have a patient from a rural setting who has put in together everything they have just to get the genetic testing done because they have seen their proband suffer or somebody in the family suffer. So that's quite unique when you're dealing with patient uh, accessibility. Yes, it is. It depends on demographic and where they're coming from, but then the knowledge and awareness about testing is something that is very unique. So Niharika, how was your experience like also in the US and also in India? Because in the US also there are like rural parts and urban cities where it differs. But what were the typical differences that you spotted in both the countries, and what were unique takeaways in India, especially?
I definitely like I was just thinking of saying that the disparities between the rural and the urban divide are something that
Mm.
aren't restricted to India isn't restricted to India because while India has like a much more significant disparity in terms of like
Mhm.
healthcare access to healthcare in general, like not just genetic care,
Yeah.
every like genetic counselors, geneticists, genetic experts around the world are very limited. Like the number of people that we have in this specialty is very low. And so access to genetic care, even in rural parts of a rich country or a white
Mhm.
country, are going to be less when compared to the urban care that they received. But what I'm trying to say over there is over here, I'll see patients from a rural background who have had lacking medical care in general, and they're coming but because I practice in Bombay, they're coming over here to receive better care or to receive answers or something like that, and their whole their medical investigations are limited, the access to care that they've had is limited. Whereas like when I compare my experiences in the US, I would see patients from a rural population all the time, but I would see gaps in terms of their genetic care. Like I would see tests ordered for unnecessary reasons. I would see tests ordered without a pre-test counseling session, or an improper assumption that a VUS is a diagnosis, or an assumption that a VUS is irrelevant, like things like that over there. But the rest of their medical care was pretty standard. Like I wasn't concerned that they weren't receiving access to life-saving medical care during an emergency
Mhm.
or something like that, which is something that I do see over here sometimes. I'll see patients from smaller towns in Maharashtra, and especially over telehealth appointments where their doctors might be present or be helping out with the appointment as well, and noticing things happening that I know wouldn't really happen over here in Mumbai at least. And so that's interesting. And what you said is also definitely very true, where I'll see sometimes patients over here from the most wealthy or affluent backgrounds, who theoretically should have access to everything in the world over here, especially since
Mhm.
healthcare over here is so dependent on how how much money you have, how much privilege you have. Like you would expect them to have good general and genetic care, and they won't have access to it. And so it's so sometimes random, where I'll see what you were saying exactly, where patients will walk in from a poor background, but they'll be managed appropriately. And then sometimes patients will walk in, be at the best hospitals, and then someone has told them that, they should get mastectomy for a VUS that's appearing likely benign on Clinvar or something like that.
Mhm.
So yeah, lots of there are some things that, like across the world, where there's some problems that we're all united in, that we're
Mhm.
facing, and that there's limited access to genetic care in general. But the specific problems that we have in each country or in each locality really really vary depending on those different factors that are at play. Yeah.
Yeah. And also, I don't know if you encountered it during your rotation, but in India, there is this in patients, you see this where there is a hope they have. I think patients universally will have this hope, but especially in India, there this hope that, okay, this testing is going to give a step towards cure. Like
Yeah, that's
something is
yeah,
going to make
yeah.
everything all right. And when you're dealing with something wherein they have not been had a pretest session and they go to a session, even with like a pathogenic finding or a finding that is ascertaining a diagnosis, we still don't have much to say in terms of cure. Like they're
Yeah.
like, okay, is there a cure? Can this be? There is this term that I used to encounter in clinics in India. That was like, will everything be normal? Will the child be normal in quotes?
Yeah, yeah.
That's something
It's
I think challenging to
yeah.
deal and explain them that okay, this is where we get a diagnosis, but then now it's management and not exactly the cure that we're looking for.
Yeah, really hard. And I think that's something that's really hard universally, like you accurately said. Like anyone receiving a diagnosis is thinking, like we are thinking, what is it? But no one else is, like the patient themselves is not thinking, what is it? They're thinking, how do we fix it? And so after receiving the answer to what is it, I do experience in both settings the
Me,
letdown of, oh, we don't really have a what next other than like management. And some of these management
I
and it's difficult to explain to sometimes to patients that some of this management, even though it's not a curative treatment, is life changing and can be life saving. Like just
Mhm.
appropriate physical occupational therapy, speech therapy in Down syndrome works wonders. So but it's really hard for a patient to receive a diagnosis and not be able to cope with the news that, oh, I can't just take a tablet and all my problems won't just go away as a result of it. And I like Yeah, I can't I can't blame them because over here we've been trained for years to look for diagnosis and help someone find an answer that we're also desperate for, like we're searching for an answer, but they're the ones coping with the question for their entire lifetimes. And so yeah, that's definitely something that's a challenge, I think, everywhere.
Yeah, it is. I mean, just I mean that's the whole uh, the primary thing of medical is like to get a diagnosis, but
Yeah,
then from a patient's perspective, it's always like when will things be better in terms of like getting a solution, and
yeah.
that's fair. That's important for them. Anybody here would like to discuss how they encountered like disparity in genetic test accessibility, or how they experienced that they became like an advocate, like okay, this is the testing that is required, and they pitched in. Would you like to share some experience? Anyone here with pre-test or any patient where you were like, okay, this patient needs a genetic test, and how was your experience with that?
Niharika, my name is Mukta. I'm so glad to join. This is my first time joining. I would like to say that I'm a genetic counselor in the US. I'm actually 4 hours away from Atlanta. So I'm in Savannah, Georgia. So definitely a rural population that I see. We just do genetic counselors, like literally spanning 5 hours distance from us. So I really appreciate you writing a lot about this and talking about this as well. And I agree with what you've said that it's so challenging, even in the US when we talk about VUSs, because it's just difficult. It causes anxiety, especially if it's related to a condition. Like if people have generations of breast cancer and it's a VUS, that doesn't go away from the patient. They always keep thinking about it. I want to address one thing that once it's classified as a VUS, it's such a challenging thing if it's come back likely path in the future to call the same
Yeah,
family after several years and be like, now we found something. And it goes either way. You will have patients who'll be happy because they'll be like, okay, at least I know what I went through has a reason for it. But then you have another set seeing that I wish I knew this earlier. I could have gone 10 years of more screenings. So it's just so hard to have that conversation with people who had a VUS many years ago, and now we're calling them and being like, remember that one thing that
yeah,
probably you don't remember anymore? What do we do about that now? So I
yeah.
just wanted to say that those are challenging conversations as well to have.
No, definitely. And I remember a few years ago reading this paper that was talking about the rates of patients remembering a VOUS diagnosis or remembering a
Yeah.
diagnosis in general. Like people are obviously more likely to remember
Hmm.
likely pathogenic variant, but a lot of patients just forget that they ever had a
Hmm.
VOUS, which I get, especially depending on the way that we disclose them. Oh, like whether we think that they're likely causative or whether
Hmm.
we think that they're likely irrelevant, especially in a cancer context, if we say this is likely not important. And
Hmm.
then, so a lot of them forget that they exist. And then later, 4 years later, getting a call out of the blue saying, hi, remember
Hmm.
the thing that I told you about? And they're like, what thing? You told me that nothing was found.
Hmm.
I can imagine that that's just such a distressing and confusing conversation, especially when it doesn't happen always, but there's this aspect of
Hmm.
blame of like, you told me not to worry about this, and now you're telling me I have to
Absolutely.
worry about this. And so, yeah, just challenging conversations we're dealing with on a daily basis all over the world.
Absolutely.
Yeah.
Yeah.
I would also like to add like cases because I am a cancer genetic counselor. I would also like to say that conditions which have clinical diagnosis, like tuberous sclerosis or NF1, and when you get a VUS in that, that's another level of challenging thing because it has a
Yeah.
clinical diagnosis, but be a VUS. And but the only
Yeah.
good thing about those disorders is you can at least manage them based on their clinical symptoms.
Definitely. And I like sometimes I look at these conditions that have clinical
Hmm.
diagnoses that you can make NF1, tuberous sclerosis, things that you said, and or even honestly to that extent, metabolic disorders that have like a
Hmm.
biochemical test that will tell you yes or no. I sometimes, half of me sometimes wishes that everything had that. So like, oh, I have a confirmed yes or no thing that I can go back to and say,
Absolutely.
okay, who's relevant, irrelevant. But then there's
Yeah,
like these, there's those,
because
there's patients who'll meet like half the, like one criteria for
hmm,
NF1, but not others. And it's just, I wish it was more objective than it is.
yeah.
But yeah, yeah,
The other thing I would like to add is, I've practiced as a laboratory genetic counselor in India, so not much more experience in terms of counseling in India per se. But I had this thing wherein, you're in the US, when you do have a VUS, you can go back to the lab and ask them, like certain labs have this blurb in there saying that we have a family testing program. um, can we test relatives who have, actually, as you know, that the good fit is the person who has the cancer rather than the relative. So can we test the family members, see how you can do a segregation analysis in the family to put maybe a PP4 score and then upgrade it. Is that done in the Indian context? I just wanted to get like more information if you are aware of that. Those kind of studies happening.
I I do think first of all, thank you, Mugdha, for sharing your experience, and thank you for joining
Oh,
in.
thank you.
But yes, I think in Indian context, I'm not sure about pediatric or prenatal setting. I think pediatric to a certain extent, but in cancer, there are these family member testing and segregation analysis testing options available, wherein testing labs, I think established testing labs at least give you an option that if you have a VUS and if there are other family members, we can test them for that specific variant, wherein you can see if that particular variant is present in the affected member or unaffected. But again, it all depends on whether the patient with a VUS comes back for a post test, and are they really accessible to explain them that, okay, we have a VUS, and then if there's any more affected members, we have a co-segregation analysis study available. So again, there is availability, but then again, it stops at accessibility because it becomes difficult, wherein the patient is like, okay, it's a VUS. And we have had cases wherein the doctor has said, oh, it's a VUS, you can just ignore it. And they have just, patient has completely forgotten about it, like you said, the phenomena. And then one fine day, you might find patient coming back and they say, oh, one other family member, they are also affected. We never told you about them. So is there something we can do? And at times there is like they have done an exome and they have got the same VOS. And then
Yeah.
almost are like, okay. And then there is like we had like a patient wherein they had like a same PALB2 VUS found in two different sisters who were affected with breast cancer at different points of their life. And it was like a whole thing that, okay, then why did my doctor ask me to do this whole testing when we knew there was something? And then it becomes a challenge to explain it because you have to handle that, okay, you're not going to put down the doctor as well, and you're not going to say them that, okay, so you have to really go in the territory very cautiously when you uphold all the legalities and ethical rights and kind of see them, okay, it's fine. They wanted to look at a broader thing, maybe they want to see if there are other genes and all that. But yes, there are these programs available. But then, like I said, it all depends on if there is an accessibility, is there an awareness about these testings with the clinician, with the patient, and how they have been told about this information. Because there are a lot of cases wherein there could be a pathogenic finding, and based on the family dynamics, which is very unique to India again, they might not disclose that to other members. And we have had patients who have had their relatives come in that, okay, we also have this particular condition in our child. We got to know from a certain someone relative that, okay, my sister had this, and we are like, okay. So it becomes a challenge that how they are accessing the information and how they have been told about this information. So I do think that to answer the question shortly, some labs do have the option, but
It
again,
comes with its own challenges,
that
as you
comes with
said.
challenges.
Yeah,
Yeah,
I think with
definitely.
that, like the segregation analysis part that you've said, so I do that on a daily basis. Like a lot of cases wherein we have tested the proband previously, and then because so that happens a lot in pediatric, like intellectual developmental, global developmental delay disorders, and there's also cases wherein the only clinical indication is just autism, and for those also the proband sample is coming in, and they're mostly more often than not just identifying het ADVOS, right?
Yeah.
Because there's very rare chances that you get a ekdam correct pathogenic, likely pathogenic AD match in those cases. So we're reporting het ADVOSs, and then the parent sample is coming in. Thankfully, it's nice to have those samples come in of the parents to see whether the variant is present in either of the parent, because if it is, then the entire diagnosis, the entire counseling just changes completely, right? Because with just the proband report, we would have said, okay, this may be can be causative. But then if the same variant is present in either of the parents, then the all of it just goes
Yeah.
away. We have to reanalyze the sample completely from scratch, that okay, this is not it. There has to be some other variant in it.
Yeah, I feel like that's part of my daily life is, oh, a variant, a het Woos in an AD condition was identified in a proband, send segregation testing. It's inherited from the mom or the dad. Oh, but there's reduced penetrance and there's variable expressivity. So it's maybe that, or maybe we have to think about repeat testing. But yeah, I do think that segregation does play such an important role in classification of Wooses around uh, the world. Something that I will say that Mukta brought up and that we've been discussing in general that I think was helpful. And Mukta, you can correct me if I'm wrong, as well as the counselors over here, please correct me if I'm wrong. But something that I do miss from my practice in the US is when a WOOS was identified or when a variant is identified, segregation testing or like assessment of inheritance is often offered free of cost by laboratories. Like there are options that, oh, we identified this and we'll help you check for it in your family members. Just send us your samples. And that's lovely. And segregation testing is lovely over here as well. And I'm so happy to offer it to families and give it to everyone. But I think there's not even this expectation over here of like, oh yeah, it's a test, you have to pay for it. That makes sense. But I think me having this experience of knowing, oh, back when I was there, I would just tell them to draw their blood and it would go and it would be covered. And that, oh, you get two variants that you can check, people that you can check this variant for free of charge, which would typically be the parents. Just knowing that that was an option that was available that isn't as available, and contrasting that with the average patient income over here, where I see less affluent patients who are less able to afford it having to pay for more for testing. But it's so variable, and I know that practice dynamics change over here and over there, and there's no like, oh, there's only free of cost testing here, no free of cost testing here. That's like not true. But it's just something that I think about, and I'm wondering if anyone else has any perspectives on, should segregation testing be free? Is it supposed to be charged? Like how are we handling this?
I do agree with the contrast because in India, I think it depends on lab to lab and hospital to hospital and who the provider is.
Yeah,
Because I know some labs wherein it also depends on the clinician, how good of a rapport they have with the testing laboratory. When they
definitely.
could put in a word and they say, okay, for this patient, again, there are all like these social factors, economic factors, and how well the doctor knows about the the whole scenario about the patient, like where they're coming from, how's their finances looking. I do know a few labs who used to offer free of cost segregation analysis, but then considering the cost of testing and in India
Yeah.
and disparity, they couldn't afford it to much larger population. It was limited to certain patients or variants that were of interest to them. Maybe again, it's fair. Like it differs. Like the testing scenario is very different here. But then yes, I think it should be free in some laboratories where they get like good amount of patients and they see VUSs on larger basis. But then again, that all comes down to having unified recommendation, unified testing strategies across the country, which are very differing right now, is what I feel.
Yeah, that's such a challenge because like I remember, and I don't know if it's there, like what I have very limited experience in the US now that I've come here since graduating, but I remember over there that one of the labs that used to offer this free of cost testing was in Vitae, and then they subsequently went bankrupt. And so just the thought of like genetic testing, we've been told for the past few decades, oh, it's getting more profitable, it's getting cheaper, where like the rate and the expenses of genetic testing are going down, it's becoming more affordable. But the reality is like it's not affordable for the patients. It's not affordable for the testing lab who's running all of these tests. And then to think about like offering free of cost testing is a whole other question. But you're absolutely right in what you said, where over here things tend to be done on like a patient by patient basis, where a clinician will look at a patient and say, okay, this one is really like they can't afford it. I'm gonna write to the lab and get an exception for them. And it really will like depends on the clinician, depends on the patient. Whereas my experience over there was like it was more standardized. Either everyone gets it or nobody gets it. And so those are just some interesting points. Does anyone else have thoughts on free versus charged segregation analysis?
I
I
would like
remember
to.
getting, sorry, someone, Hi everyone, good evening. Nibby here. So sorry I had to drop in and out. I was in transit. But I think in India, this is on a case to case basis because mutation specific testing by Sanger for specific variants does not cost much. It's like maybe 4.5, 5,000. And so if I do have a family where they're not affording, I request the labs that I work with, and they actually sometimes waive off the charges completely if the affordability is an issue. And in cases where there are a lot more family members, like say 6, 7 family members who need to be tested in large families, they also bring the cost down because of the volume of samples that go up. So I think in India, like for me, if the patient's affording, if the family's affording, I send them through. But then if the family cannot afford the test, I actually request the lab and they actually help out. Most of the times that's been the case.
Yes. Also, to add on to this discussion, I had a very interesting point, which Niharika, you have mentioned in the paper. What really changes the game in India is, for me at least, from my observation and my experiences, knowing the patient's language. When you have a patient who speaks their mother tongue is same in which the session is being conducted, it makes a huge difference. Wherein my mother tongue is Marathi, and when I see a patient who's comfortable in Marathi or Hindi, which I am very fluent with, it's a very different connection they feel. It's a very different way they respond. They're more receptive, and I've seen it with other languages also. Wherein if you have a counselor who speaks the language of patient, their reception, their understanding is much more better. Their involvement in making the decision is little bit higher because we have seen that when you talk in a language, maybe like suppose Hindi, that's very widely spoken in north and west of India, and you're counseling patient in Hindi, they will take the information as if they're taking from a doctor. They'll accept the decision, but when the switch happens, wherein they know that okay, I speak Marathi, which is also our language, their involvement is different. The way they understand VUS is different. The way they understand the options is different, and I think that makes a difference. So if anyone have experience with that, like how speaking the language changed the entire thing for a patient, we would like to hear those experiences.
Absolutely. I think the level of rapport that someone has
Yeah.
when they hear, "Oh, this is my language,"
Yes.
is just like another, it's something that's unmatched. And it was especially so valuable and meaningful for me to see over here, given that the way that it works in the US is that they'll have an interpreter over there. Even if even if someone is a native speaker of the language but they're not certified to practice in another language, like they have to be certified to provide medical care in that language, not just local native fluency in that language before they're able to like provide a counseling session over there. And I think it's wonderful that they have interpreters for so many different languages that are able to provide care for patients that speak like languages that are less common, and that's great. But over here, like when you see a provider switch to a language that a patient understands without a middle ground, the value and the impact that it has really is really something else.
Yes, it does because I've seen and also it changes their perception with the clinician, wherein they go back and tell all the information, and the clinician is also like, yes, I see the value of the genetic counseling session, so I'm going to recommend patients here
Yeah, because
because
the whole point of genetic counseling is like putting complicated genetic information in easy to understand ways for patients to be able to grasp and move forward. And are we really doing that if we're not speaking in the language of the patient's comfort, if the patient isn't hearing words that they actually understand? So, yeah, definitely.
and this has been a common experience because I remember even Akashi mentioning that when she started practicing, she got to know the words for the word gene and chromosome in her native language, and that made an impact. That made a difference, and it makes a huge difference because I think in my experience, when I had patients with VUS and I know their language, it's much more easier to tell them that what has happened, what has gone wrong, wherein they exactly understand that this is not something to completely ignore or this is not something to stress a lot on. And as opposed to if you have like uh, some other language which is in common, like, okay, which is not exactly their native language. But yes. And I think more and more as the field is expanding, we have genetic counselors who speak the native languages, and we see a lot of content in Indian setting that is coming in, being translated in those native language, and that is making a change. But then again, we have a long way to go wherein everyone has access to a genetic counselor who speaks their native language, and everyone
Yeah.
has means to reach out to a counselor who speaks their language. So
Yeah, it's such a challenge. It's like I also want to clarify that it's so lovely when you see patients, like when you see providers being able to counsel patients in the language of their preference, and that makes such a difference. But where like I think that interpreters provide a quality of care over there that like kind of standardizes the experience but never reaches the level of elation of like, oh, a Marathi speaking counselor working with a Marathi speaking patient. But then when a Marathi speaking counselor interacts with a Tamil speaking patient, Malayalam speaking patient, someone else, a different thing, it's like the whole standard of care and situation switches, because then there's no interface, there's no middle ground. Whereas like there might have been in another country or in a hospital that has, like over here there are definitely hospitals that have interpreters that are available for patients who can afford those that standard of care, and that like provides them with with a baseline. So I think what I'm not able to conceptualize it or see it as clearly as I would like to, but I think that like interpreters and having access to translation services like enables like this middle ground that gives patients like a quality of care that's not excellent, but at least it's in their language, like it's above average, it's in their language. And then if you have a person that speaks the native language or speaks the local language, like that provides excellent care, that's phenomenal. But then suddenly when they have when they're either practicing in a population that they're not local to, or when a not local patient arrives, then they have no services to be able to provide that patient with a level of care. So yeah, trade-offs everywhere.
I think in Indian setting, also genetic counselors take up the role of interpreters in
Yeah.
different settings. Wherein, like I have worked with a clinical geneticist or a genetic counselor who speaks English or Hindi, but the patient is speaking Marathi, and then you have to kind of. And I've seen people, counselors who speak Tamil, also do that for other
Wow.
sessions, and it does. I think it used to happen with Nivedita and me, when we used to have patients who speak our languages, and we used to like be interpreters. But it used to make difference because even when you're speaking Hindi, or the patient also understands Hindi, but the native language is something else, Marathi maybe. Uh, they understand Hindi to most contexts, but then
Hmm.
if you put in the words, like some
Yeah.
words in Marathi, they understand it better. They get, okay, this is the context, this is what they're trying to say, and it really becomes information which they can take in, which they can digest.
Yeah,
I also,
definitely.
I also feel like we all, as humans as well, have like a language that we're all comfortable with. Like even though I talk in English, Mayuresh, I talk Marathi all the time, and I think I can express better when I talk Marathi, like my fears, my emotions, and I think that's the same for the patient. Like they, if you explain them something, it's easier for them to also reciprocate back and tell like what they understood, what they didn't, or even express their fears in that language, which I find sometimes even with interpreters in the US, it's really challenging when I'm seeing someone, let's say a Spanish person or any other languages that I'm not aware of, to kind of get that reciprocation emotionally. Like, even if you're asking those questions to the patient, like, how are you feeling about this? But it's really difficult for the patient to reciprocate that back because it's not their preferred language.
Yeah.
Definitely. That's
Sorry to just
also
jump in.
no, no,
No,
that makes so
no.
much
Free
sense
to
and it's
do
so
that.
important. And like, it's also that it's so challenging because I feel like there's different languages on multiple levels. Like we're all communicating like this language of genetics, which is this a whole other language. Like I don't think it counts as English also. And then like thinking about interpreting that into English, or then interpreting that into another language, translating that into another language. There's lots of levels of rapport that we're trying to cross to enable like effective communication.
I do want to add one thing. I know we were talking about, Niharika, you brought up that good point about like free testing, and how it's done in the US. I do want to add that, at least what I've seen and noticed in the US, it's not offered for all genes. So like most of the labs, yeah, as you're saying, because most of the labs are also going bankrupt, they're offering free testing. It's It was first NVT, now GeneDx doesn't offer
Yeah.
cancer testing anymore. So it's going to that route. So they're not
Yeah.
offering free testing for all genes, but they're in the cancer setting at least, they're only offering free testing for VUSs, which are high risk genes. So
Mhm.
I
for BRCA,
see.
BRC, so if you'll see the reports, you'll have for BRCA, they will say, okay, we offer family testing. But for an ATM or a
ATM.
check
Yeah.
too, they wouldn't do the same.
Yeah.
So
Yeah.
that's where like I think they are also trying to make it and also I think from what I when I reached out to the medical science leaders of the labs, they mentioned that they wouldn't do that for a moderate risk gene anyways, because the evidence they would need is much higher than just co-segregation analysis at that point to make sense. So they wouldn't just
Ah,
spend resources on that at this
I see. So
point.
they're only willing to like offer
Yeah, because
free
with moderate
testing. Yeah,
penetrance,
yeah.
you just don't know whether that's actually causing that in the family, so they don't want to spend the resources
Yeah.
for that. What I would also like to add is whether it's India or whether it's US, I have offered this family program to a lot of my patients who did come back as VUS and have like a really vast family history of cancer. It's more difficult to get their families tested when it's a VUS versus when it's just a path. Like when it's path and you have like making clinical decisions
Hmm.
on it, they will easily convey that information and be like, oh, we need to get them tested. It's free in both contexts, but
Yeah.
the kind of approach that the patient has towards that, it's like I've had patients who, again, well educated, well background, and when I've explained the VUS and said, like, this is free testing, you can ask your sister or your parents to get tested to kind of answer that for your family. The reciprocation is lesser as compared to when it's just a likely path or path, because it's more like, okay, we can do
We know what it
something.
is. Yeah. That's so interesting. Like the levels of at the patient level, the reception and the willingness to perform further testing depending on the clarity or the classification of the result. Yeah, definitely. And it's interesting to hear about the update with respect to what testing labs in the US are able to offer free of cost. And I think that's so like I just a year and a half ago, I was in the US and it's changed. And so I think that's just representative of how quickly this field is evolving everywhere. And like over here, I'm sure if I leave for a year and then I come back, everything will be different over there. Like it's the same. This field is really just running quickly. Labs are offering free things, taking away free things, profitable, not profitable. Patients are benefiting, not benefiting. Things are changing everywhere. Yeah.
Yes. That's interesting takes to listen to. Also, we are running a little bit out of time, but then if you choose to stay, we are going to discuss this one last point because this is very interesting in terms of Indian setting. I think we discussed this in the journal club meetings, which was disability and how there is a huge disparity in India about it. Like when you compare to US, uh, the access to resources what a disabled person have in the US is way different than what a person in India would have. And the ableist language or the language where we address disabilities in India is uh, I would say is a little bit flawed. Is a lot flawed. And when we see patients who are going to require, like there are so many hospitals in India or places where genetic counseling sessions take place for patients who might have disability, where they don't even have a accessible ramp or they don't even have like a good wheelchair service or an elevator service where they can access it. So, what was your experience in terms of that, Niharika?
Yeah, this was one of the most impactful parts for me, like the views and training and experience with disabilities over here versus over there. And I of course want to emphasize I've grown so much since I wrote this and since I had these experiences. And of course, not everywhere in India provides the same or uses the same type of language. And not everywhere in the US, like there's lots of wonderful ableist places in different parts of the US. But I think that when I was receiving my training, there was so much emphasis on disability care and how we defer to people with disabilities and how we talk about mutations as differences versus mistakes. And
Mhm.
like just the small differences in terms of language that we use with respect to patients. So I was quite shocked when I came over here and saw different. Of course, it really, the thing is, I feel like when I was there was this standard equilibrium in terms of like, this is the type of language that I see people use. It's pretty standard. Every genetic counselor who's gone to an accredited program is going to be speaking the same language essentially, regardless of where you get them. And over here, I would find like some of the best genetic counselors I've ever met. I've met over here. They've like really amazing rapport building with their patients, really excellent genetic knowledge. But then I've also seen counselors use language or be very directive in their counseling, tell patients to abort a fetus that would have a disability, or like have certain tonalities in like, oh, disability, like this is equal to good and this is equal to bad. And it's so challenging, and I've dealt with these questions regularly in terms of practice as well, where I think about things like prenatal diagnosis for achondroplasia or something else that's associated with like isolated short stature and not really intellectual or developmental morbidities, and the way that we perceive difference in general as disability. And oh, I don't want to put my child behind in this rat race or anything like that, or like, I don't want my child to suffer. And it's this question of what counts as suffering. Like, would you, definitely in achondroplasia, you face that risk of spinal stenosis, and there are definitely medical morbidities that are attached with it. But there are some conditions that might be considered disabilities just because society isn't structured in a way that can help them reach, like, that provides them opportunities, basically, because society is structured for like the average individual with the average height or the average level of functioning. And I don't know if it's fair to think of that as a disability, but then giving a patient a diagnosis, like, it's not obviously, it's so challenging because these issues are so systemic and the choices that you make are so individualistic. Like, of course, the I want to be there to provide care for patients so that they can make informed decisions. But if their informed decisions are influenced by societal standards and availability of care, how can I judge them for that? And they're just, it's a very strong, deep rooted topic that I think about regularly. I think about my own ableism. I think about the ableism that we perpetuate, the care that we're able to offer to patients, depending on, like, because how is it fair to say, oh, it's a systemic issue, it's a social challenge, like, but if they don't have access to resources, of course it's more than a social challenge, it's an existence challenge. And so it's just, I know I've been like honestly kind of rambling and there's no coherent thought process, but this is something that I think about every day. And I think about I don't know, it's just such a challenge. And there are limitations in how we address disability and ableism in all countries and around the world. But it's an issue that I'm glad that we have at least this platform where we're all talking about it, because I think I would go crazy if I didn't have an outlet to say, like, oh, I'm having all of these conflicting thoughts and ableism versus choice and autonomy, and I don't know what to do with it. So I'm just eager to hear anyone else's thoughts, and maybe someone who's a little more coherent than I am and is able to put their thoughts more clearly.
I 100% get your rambling on the disability issue, because also, like, when I was working in India in genetic counseling settings, I had encountered with this word that, will the child be normal or will there be
Yeah.
normalcy? And there are like patients who had severe medical issues going on where they needed genetic diagnosis, and uh, there could be family members who would bring up like, will this proband be able to get married, will they have a normal life, will they have
Yeah.
the life what they're expecting like people around them to have. And I used to be like, there are so many issues that are
Yeah.
needed
Like,
addressing
what
currently.
is normal? What is
Yeah, and yes, like you said, like you as a genetic counselor, you encounter your own ableism and you see yourself using those words, and it changes your perspective that, oh, this is something that was taught to us. We learned it because we are also part of the society, and then you're like, oh, this is how we unlearn and this is how we improve as genetic counselors. But yes, that awareness is there, is coming, but then yes, not at a rate that it is required, because India is such a huge country, and apart from genetic disorders, there are disabilities present everywhere around us. And at least in India, my experience is it is such a segregated section wherein you see that in our society in general, like again, this is my rambling. Society as a general, we have very small window for people with uh, different needs,
Yeah.
differently abled people. They have very less window to interact with the mainstream society.
Yeah,
Like I,
definitely. I know exactly what you're saying. I didn't mean
yeah,
to cut you off. Please continue after this. But I was just thinking, like, we don't see disabled people out in the open anywhere. And I remember being in different countries and seeing minimum one person with a wheelchair, someone with like
yeah.
various different needs running around. And yeah, but you were what were you saying after that? Before that?
So my undergrad college, we had like a Braille association wherein we used to go and interact with people who used to read Braille and who had like visually impaired people, and it was such a good
Pixie,
experience because
वो नहीं
you
करना
see
खराब.
them, you
नहीं
understand
नहीं
them,
नहीं.
and
Hey,
that is your thing to be a part of. You basically, that was the window where they could be part of this mainstream society, and we are like, okay, how little knowledge we have about these people who live around us or present around us. And that really changed my perspective when I was counseling patients who would have some visual issue or some ophthalmic issue, because there are resources, there are things that these people are doing amazingly well, and it's just that we don't have knowledge about them, we are not educated about them, and
Yeah.
nobody in society talks about it. Like
Pixie,
I remember when they were
Pixie.
having this one session for a patient with wheelchair, and the doctor was like, okay, just get them up. And we are like, how are they going to come up? There is no ramp. Your elevator is small. Your elevator is not made for
Yeah.
somebody to get in with a wheelchair. So it is just that uh, it's so weird
I
that people
know.
who see these patients on a daily basis have little knowledge. Okay, how are they going to get up?
Yeah.
And
Yeah.
it used to always be like there was people who should lift, and uh, we I think uh, in that period I also learned that okay, we as people think that okay, it's just utalo, bring them up and everything, but for the patient, for it is very rare
Dignity.
that people try to
Yeah.
understand what they are going through, what they want, what they need. But yes, that education is much required, I would say, because
Yeah.
that would also make us strong advocates for uh, people with disabilities in India, because like you see, it's a huge country, and if that country doesn't have resources for those people, we are clearly lacking
Yeah.
as people who are part of this bigger system. So I feel.
Definitely. I and like this one thing that I want to say isn't related to my experience as a genetic counselor. It's related to my experience as someone who's like I grew up in India, but I spent like a few years here back and forth in the US as well. Like I did go back and forth. And I do remember that in my schooling in the US, like I would have been in first standard or something like that. And we had a deaf student in our classroom. And so we all learned American Sign Language. Like we learned how to communicate the alphabet. We learned like 1 to 100 or whatever, and we learned those things because because these people are people who exist in our society, and we should be able to communicate with them. And that was just such a normal thing. There was just so many normal accommodations and facts about accessibility that I saw just by living, not because I was a genetic counselor, not because I was practicing in a field that works with disabled people, but just because I was living as an individual. And I think you're so absolutely right when you say that if we as genetic counselors at least do our part to like change ableist notions or to open people's eyes about disability, because we like the way that our general society is built right now, like the average city, like cities are better than rural areas as well, but like the average city does not consider a wheelchair ramp, does not consider a lift that's big enough to accommodate a wheelchair, or a mall will just have like an escalator where what do you do? What are your options if you're not mobile? But yeah, I think that things are getting better. I think I've met some phenomenal genetic counselors over here who've really opened my eyes to like how we can use words differently, how we can use language differently, how we can care for our patients differently. And I think if we are able to do our small part and educate the people in our lives, like slowly change will come, because these people exist everywhere and they're just often hidden at home because they don't have access or ability to come outside. And they do exist, and I just hope that like slowly we can do our part to help bring them out and help them be
Yeah.
around. Yeah.
And also because addressing these notions, uh, forget about society, but also for patient and their families is so important, because oftentimes we see they have understood these medical terminologies as a label, a taboo word, which is gonna
Yeah.
ostracize them, which is gonna leave them out of mainstream uh, playtime or society. Because uh, I remember one of the patient just using that "मेरा बच्चा तो पागल है," and
Yeah.
the whole term was like,
Yeah.
and we were like, when you say that, it really has such a negative impact on people around them. The
Yeah.
siblings have started using that word, the uncles and aunts who used to use that word, and we are like, I think there was a very interesting session when we tried to bring in that, okay, your child is doing so many things, and you just labeling him pagal just makes it. Uh, and but that session made a change. Like it can make a change where how people
Yeah.
look at their own child, and also then it opens up, it educates them, and they can educate people around them, which will
Definitely.
patient. And as we know, if patients become their own strong advocates, there's nothing like it.
Yeah, I also want to say that I've learned the most about disability from my patients and families with disabilities. Like, of course, of course, there are definitely families where I've like it's hurt me to hear the words that they use for children that are in their lives, or like words that they would use for a fetus that is developing that might have different abilities or anything like that. But there are also families that have lived with disabilities for 10, 20 years and just talk about their kid like, oh, he can do anything, they can do anything, they do it a little differently but they do anything. And it's been so heartwarming to see how people grow around their different needs and abilities and how they address it once they have that lived experience. And it's really changed my lived experience to have had the privilege to talk with them and learn from them. So yeah, I think they're educating us, and we hopefully can pass on that education to different people. Yeah.
I'm sorry to be the party pooper, that we
No,
are
I know.
have to wrap up this discussion. It was amazing to discuss this paper, and it was amazing to have you here, Niharika, because we got to know about everything about this paper from the real author. So it was great. But yes, our key takeaways were increasing access of genetic testing in India, speaking patients' language, the impact that it can make to speak patients' language can make them and their understanding very different, and it can increase the access of genetic testing and the way of their involvement in genetic decision making. And also, it opens up discussion for genetic counselors to become advocate for disability rights and kind of addressing those issues as well in genetic counseling sessions, because once you educate patient and you learn from them, there's nothing like it. And yes, so on this note, we'd like to wrap up this discussion. If anyone would like to discuss any papers and interesting cases, feel free to email us and feel free to reach out to me, Sukriti, or the GC Club. Looking, we hope we see you again in next sessions and we would have more lively discussions.
Yeah.
Thank you so
Thank,
much, guys.
thank you so much for inviting me here. It was such a lovely time. Loved discussing with you and
Thank you
having
for
this
joining.
conversation.
I
Thank you for
was very,
joining.
very surprised when Nija ma'am
Yes.
tagged you. I was like, oh, okay. You know
It
that
was
thing when you read poems when you're a child and the teacher is trying to explain to you what the author was trying to say. Here we know what the author was trying to say because you're here with
Yes.
us.
thank
We
you.
did.
Thank you so
We,
much.
we didn't just interpret that the curtains were blue.
Yeah.
We
Yeah.
heard from the poetess that
I
yes, the curtains were blue.
exactly. They were blue and
Yeah.
yeah, it was so lovely. Thank you so much for calling me. Thank you so much for this lovely discussion. Really enjoyed, and I hope we can continue talking and meeting in the future. Yeah.
And also the
All right.
ramblings on disability is something that is, so please,
I'm sure
please feel free to
we
pop in.
yeah, we I think we all need that outlet, and I'm glad that we
Yes.
have this at least shared community with shared experiences where we're all like, hey, what's